Good morning and welcome to today's Ask the Doctor panel. I'm Guadalupe Lara from La Sed Senior Wellness Center, and I'm so glad to be here with you today. It looks like we have over 700 people on the Zoom with us, which is quite outstanding. At the bottom of your screen, you have an icon that looks like a globe. Simply click on that button to select your preferred language. We're doing something very exciting here today. Today, our hope is to connect each of you with information and resources you need to live a healthy life. Our program today is brought to you by your trusted friends at AARP Michigan and by several local organizations that you will see on the screen, including my own La Sed Senior Center. The panel of doctors that were assembled today is actually the first event in a three-part series called The Color of Healthcare. We know that not every person or community has equal access to the healthcare services that they want or need. So this three-part series is intended to spotlight the inequities of our healthcare system by hosting community conversations that we hope will help bridge the multicultural healthcare gap that too many people in our state experience. But before we get started, I want to cover some housekeeping details about how today's panel will work. We know we have people joining us from across Michigan, including several non-English speaking communities, and we are very pleased to offer you today's program in the language you require, including English, Spanish, Chinese, Korean, and American Sign Language. Since this will be an interactive program, everyone is invited to ask questions in the chat box. Our staff and translators will be monitoring it, and non-English questions will be translated for our panel of doctors. If we run out of time and can't get to your question, our staff will reach out to you afterwards with a response. I want to also alert you that we will be pausing at some point during the program to ask you a few questions about your own personal access to healthcare. This poll will appear on your screen, and you simply select the answer that applies to you. If you are visually impaired, our ASL translator will read the poll to you and invite you to submit your answers into the chat. The answers you provide are going to help define the conversation that happens in our next Color of Healthcare events. And ultimately, they will help build a roadmap for changing this narrative and closing the healthcare gap. That's the big picture behind what we're going to do today. But before we get started, I want to mention a few more housekeeping details for today's panel. Behind the scenes, we have staff monitoring the chat. And if you are having any technical issues, please send us a note in the chat and our team will assist you. This includes any issues with audio, video, and our translation services. Should your screen freeze, we suggest disconnecting and signing back on. Today's panel will include some opening remarks from the doctors, and then we'll open things up for your questions. And with that, I think we are ready to begin. Here today to introduce our esteemed panel of doctors is Shenlin Chen, President Emeritus, Association of Chinese Americans, Executive Council member of AARP Michigan, and she's also a member of the Color of Healthcare Committee. Shenlin?
Thank you, Guadalupe. Well, this day has been a long time coming, and I'm thrilled to see the inclusivity of this event, which is a meaningful moment for those of us in pursuit of equity. I'm honored today to announce our esteemed panel of doctors. Dr. Henry Kim, ND, cardiologist, Henry Ford Health System. Dr. Henry Possum, MD, PhD, Director, Michigan Alzheimer's Disease Center. Dr. Jennifer Edward Johnson, family protection practitioner Flint, Dr. Pearl Lee from the University of Michigan, Geriatrics, and Dr. Peter Cook, MD, Briscoe Ray Community Center, Lansing. Thank you, doctors, for being here. The panel will be moderated by one of our esteemed peers, Dr. Zorae Eaton, who is a living legend at MSU, where she has mentored several generations of African-American doctors, and in Lansing, where she has served the community for 30 years. Thank you, Dr. Eaton, for agreeing to be our moderator today. Dr. Eaton.
Thank you, Shinlin, for that introduction. I am not a living legend. I am just living one day at a time. Can you hear me fine?
Yes, we can.
Okay.
That's a little what we're talking about. Excellent.
I am an AARP volunteer, and as the other AARP volunteers know, our esteemed director, Paula Cunningham, keeps us busy. To start things off, I'd like to explore the impact of COVID-19 pandemic on communities of color. We know that there were many barriers during the pandemic that impacted people of color and people who already had issues with access to healthcare. The social determinants of health were in full display during the pandemic. Lack of access to quality healthcare, lack of insurance, working as an essential worker and therefore being exposed more to the virus. Income and wealth disparities, as well as mistrust and misinformation, just to name a few. We would like to start off by asking each of our panelists a brief 2-minute remark on their own perspective into the pandemic and the impact that it may have had on your practice or in your communities. And to make sure that we stay on track, AARP informed me that ELMO, ELMO, will make an appearance if we need to move things along. ELMO stands for enough. Let's move on. And with that, we will start off with Dr. Kim. If you are available, we'd like to hear your comments on COVID impact.
Yes, well, thank you very much, Shenlin, for that introduction, and Dr. Eaton. First of all, can all of you hear me? I just want to make sure. Okay, terrific. Well, again, thank you. I'm sorry? Did someone say something? Okay. Again, thank you very much, Shenlin and Dr. Eaton, and thank you very much to the AARP of Michigan for this opportunity. I'm only sorry we couldn't be doing this event in person. I'll say that I distinctly recall that Saturday in March 2020 being on call with Henry Ford leaders to create an emergency operating plan to deal with the rapid rise of COVID infections that were coming to our hospital in Detroit and the incredible impact that would have on our ability to provide care to our patients. This was just a few weeks after the first confirmed death in the United States, as you know, from COVID-19. And immediately we found ourselves overwhelmed by the influx of really incredibly sick, critically ill patients to our hospital. And of course, at that time, there was a lot of fear of this illness, fear of the unknown, and fear of bringing it back to our families. But I'll say that each day I was amazed and inspired by the teams of doctors and our care team in our emergency rooms and our intensive care units. It was also truly traumatic and traumatizing and tragic to see patients who could not breathe on their own, intubated on a mechanical ventilator for weeks, only to pass away alone without families at their side. Over the course of the pandemic, we've also had to deal with other very important issues. As Dr. Eaton brought up, patients afraid of coming into the hospital or the emergency department, even when faced with life-threatening symptoms because of the fear of being exposed to COVID. So we saw lots of patients with having heart attacks who didn't come in because they were afraid of being exposed. distrust of the medical system manifesting as vaccine hesitancy. Even now, we're experiencing, even in the aftermath of the latest COVID surge, that many nurses and staff have left the system feeling burnt out from the stress of having cared for so many of the COVID patients. And now that's left us with a lack of capacity to provide care for critically ill patients in our hospitals now, even now that thankfully COVID has seemed to at least taken a break. These are tragedies at the level of the individual patients and families impacted by this horrible pandemic. The other tragedy, however, just as glaring, is the way that the COVID pandemic exposed how inequalities in our society made a tremendous impact on how this crisis is unfolded along racial and socioeconomic dividing lines. The early phases of the pandemic disproportionately and significantly hit our urban centers, such as Detroit, when we were just starting to figure out how to treat this virus. The inability to distance as easily in an urban setting, no question, had an impact on the spread of COVID in our cities. Those who had jobs or the economic means to be able to stay at home instead of go into their offices were able to isolate, as opposed to those having to go to work in non-office-based settings. I'll say from a medical and lifestyle standpoint, we know that those patients with chronic clinical conditions such as hypertension, diabetes, obesity, heart, liver, lung, and kidney disease, smokers, those are all conditions that we know differentially impact minority and socially disadvantaged communities. And those patients clearly fared much worse when infected with COVID. And the unfortunate thing is that we've learned that the COVID pandemic not only increased overall cardiovascular death in the United States over the course of the pandemic, certainly something important to me as a cardiologist, but we now also know that the COVID pandemic disproportionately affected negatively communities of color, Black, Hispanic, and Asian communities. I'll mention a paper that was recently published in the journal Circulation, which is the premier scientific journal of the American Heart Association, reported that while the non-Hispanic white population experienced a 2% relative increase in cardiac deaths and a 4% relative increase in cerebrovascular deaths, such as stroke, the Black, Hispanic, and Asian populations experienced an approximately 20% relative increase in heart disease deaths and a relative 13% increase in cerebrovascular deaths. So while we're now focusing on how we can prevent future pandemic outbreaks of any novel pathogen, not just COVID, we must also be clearly and deliberately addressing those very clear determinants of health, things such as access to care, food safety, economic security, to prevent the disparities in income we've observed not only with the COVID pandemic, but in the many clinical conditions we encounter every day. Thanks very much for the opportunity.
Thank you very much, Dr. Kim. That was very, very insightful. And those numbers are just amazing, how it has impacted people of color, Hispanics, and Asians. Dr. Paulson, as a doctor in dementia and Alzheimer's, which is certainly may have its own unique issues as it related to COVID, could you comment on how it's impacted your patient population?
Sure, thank you, Dr. Eaton. Firstly, I think Dr. Kim's comments were wonderfully thorough, and I won't reiterate the many very important points he made. I do, as you know, focus on the brain, and we're particularly interested in cognitive impairment. And our center here at the University of Michigan emphasizes particularly communities of color, particularly the Black community centered in Detroit, which has been understudied, frankly, in dementia around the country. So I think that's a very important point. I think many people are aware that COVID affects the brain, right? One of the first symptoms often is brain function, and in long haul COVID, which is something we probably will get to, they say they can't see me. Here, now they can see me, okay. The long haul COVID can certainly affect the brain as well. So it's something we might want to come back to. I think what we've learned over the past 10 years is that dementia is not a simple thing. It's very often multifactorial, many different things contributing to dementia, particularly in communities of color. And what we're, I think, going to learn eventually is that in addition to cerebrovascular or vascular changes in the brain that might be changed by COVID, it may be itself chronic effects of COVID that affect dementia. So I would say one way that we've been affected is it's been very hard to continue research in the last 2 years. This is a minor thing. It's not about care for patients, but we can't really understand the causes and contributions to dementia without studying people. And we are beginning to get back into the mode where we can actually again, evaluate people and see how COVID has affected people. It's an important part of what we've added to our research. So I'll stop there, Dr. Eden.
Okay, thank you very much, Dr. Paulson. Dr. Lee, one of the things that I was so proud of in the state of Michigan was the vaccination rate in our geriatric population. It was up over 80% statewide. Can you comment on what you saw in your practice? Is it related to COVID?
Yeah, great. Thank you. So yeah, in my practice, all of our patients in general are very receptive of the COVID vaccine. I think that's part of it is because we have always traditionally been educating and providing counseling about vaccination in general. So we have always built up a very good report when the COVID vaccine came out. A lot of them are very receptive of our recommendations. The University of Michigan, obviously, and also the VA, which is part of where I belong to, are very good at making recommendations, accommodations, and to providing the COVID vaccines.
Great, great. Thank you very much. I think our other two panelists may not be present at this time. And so what we'll do is we will move on. We have a number of members who are part of the Multicultural Health Forum Committee, and they were asked to have their members submit questions prior to today's events. We're going to do a little round robin and ask those questions from Guadalupe Laura, as well as Dr. Janilla Lee, that have been submitted previously. I do want to do a little disclaimer and say that the doctors that are present today are not present to diagnose or treat any conditions. They are here simply to offer perhaps some advice and some information that you may be able to take away with you. Given that, we will first have questions from Guadalupe Laura.
I have a question here from Teresa Nellis, and she speaks English. So could the answer be in English for her?
Yes.
Okay, I put on English now. All right, she says that her question that for the doctor is she has allergies and she wants a general answer about is there anything that she could do to manage her allergies without taking medication?
I will ask Dr. Lee perhaps to address that.
So I am not an allergist, first disclaimer. So I think in general is to look at the environment that may be causing the allergies and try to remove those allergen agents. For example, if there are pets, if there's flowers or certain molds around the house, those are common agents that could cause allergies. So the environment would be the first thing to look into it. And then the second thing is really to work with the allergist, maybe to test to see exactly what's causing the allergy first. And see if that could be something that could be treated or could be or removed as a non-pharmacological treatment.
Right.
Thank you.
And then I had another question from a senior who wanted to know if they had had Covet, were they more prone to stroke than other patients?
Maybe that is coming toward me. I would say during COVID illness, there's clearly an increased risk of stroke. But in terms of the long-term sequela of having had COVID, let's say you had COVID and it's gone away, whether that increases your risk of stroke, there's not good evidence for that. Now, maybe that some individuals with long haul COVID, that is chronic symptoms of COVID, might have a vascular component there. But this is still a work in progress. I'd love to hear what Dr. Kim has to say about this, if he has anything to add.
I would agree with what Dr. Paulson had to say. You know, clearly, in the acute phases of the COVID infection, we were seeing a very marked inflammatory response. And that's what really it's that response to the infection that caused lots of problems. And as a result of that, you could see significant impact on the vasculature and the vessels and the wall in particular. And so people became more prone to clotting disorders. So it affected the blood cells and the vessel walls. And so as a result, we were seeing patients presenting with stroke and even acute cardiac syndromes. And we saw that in the numbers, as I mentioned in my comments.
I just wanted to add that since one of the most common contributors to dementia or cognitive impairment in people as they get older are more subtle vascular changes in the brain, there is concern that COVID itself will have precipitated more microvascular changes in the brain. Again, it's early days in terms of knowing how significant that will be. Our center, among the 32 Alzheimer's centers in the country, is looking at the COVID impact and looking specifically at how vascular change in the brain might be different in those who had COVID or versus those who didn't. But it's a really good question, and I think it's just too early to know the answer to that.
Thank you, Dr. Paulson. And just to follow up on that, we know that there's individuals who had certainly severe COVID, were hospitalized, were ventilated, who may even have long COVID following that. But there's a host of individuals, of course, who had COVID and that was considered mild, who stayed at home, who did not have to seek, medical care. Do we know at this point whether or not those individuals also fit into that category?
I can't give a definitive answer, but I would say most people who had asymptomatic infections or mild symptom infections and have made a complete recovery are unlikely to have long-term sequelae from it. The whole long-haul COVID thing is complicated. It's got at least several different components. One of them is if you've had a very severe illness and you've compromised organ systems like the heart and the lung or the brain, that can give you a long-term sequela of that. Others might have chronic infection in some ways. And the third thing is sort of this immune inflammatory component that Dr. Kim alluded to, which is something that could be contributing. But for the most part, people who had very mild infections are not going to have the long-term sequelae.
Okay, thank you. Dr. Lee, you have a few questions you'd like to ask as well from the Asian Center?
Okay.
Janila Lee from the Asian Center. Are you there with us?
Yes. Yeah, this is Janella. I think I submitted some of those questions already. I thought you guys received that, didn't you?
Yes, we did. We thought you were going to read those, but I'd be happy to share.
Oh.
But one of the questions, I do want to share that for you. One of the questions, Dr. Kim, was what are some of the common causes for atrial fibrillation?
Well, thank you for that question. So we don't know exactly what causes atrial fibrillation, but we know that, certainly as patients get older, that we see that more commonly. And there's certainly some conditions that we know are associated or can precipitate atrial fibrillation. For those of you who don't know what atrial fibrillation is, it's an irregular heart rhythm where instead of the heart beating synchronously, it beats irregularly and often very fast and places patients at risk of stroke. So patients who are more prone to get atrial fibrillation have conditions such as hypertension. They may have coronary artery disease and may have had a heart attack. Certainly patients with valvular disorders, particularly of the mitral valve or mitral regurgitation and mitral stenosis, certainly are at higher risk for developing atrial fibrillation. There are certain congenital heart diseases. And then there are certain other medical conditions that can contribute to it. So if you've got a thyroid disorder, certainly when I see patients who have atrial fibrillation for the first time, I check to make sure that their thyroid is doing okay. So there's a number of things. And then certainly, we'll see in the acute setting when patients are under a great deal of stress, that can certainly precipitate atrial fibrillation as well.
Okay, thank you very much. I see that Dr. Peter Cook has joined us. Thank you, Dr. Cook, for being with us today. I know everyone's schedules are packed, and we appreciate the time that you take to be with us. Janila Lee, you also had another question. I don't know if you want me to ask it or do you have those?
Please do, because I don't have that with me right now, so.
Okay. Dr. Pearl Lee, can you speak to what essential minerals are required for seniors?
Yeah, so thank you for that question. That's a very common question, and I get to ask about that a lot of times. In general, I think if you are eating a very diverse diet, you really don't need excessive vitamins because most of the general diet contains sufficient vitamins for us. Some of the key vitamins, obviously, we want to make sure our seniors have, including sufficient amount of calcium and vitamin D, because these both of them are important for the bone health to prevent osteoporosis, fractures, and falls. But also, you don't want to take too much of those because too much calcium could put at risk of confusions and kidney stones, etc. So we don't want to take too much of them. Always talk to your physician first and to say how much you need to take. The other vitamins I think are also important include the vitamin B12 and B6. So these are common in fish, meats, chicken. So these are important for like nerve cells. Dr. Paulson could probably comment about those as well. So those are very common in the diet. So if you eat a regular diet, you should have sufficient of those. So I generally, when my patient asks me what kind of vitamins they really want to take, besides vitamin D and calcium, I generally recommend just taking a multivitamin a day. That should be sufficient.
I just want to riff a little bit on Dr. Lee and saying that even though we say vitamins are important, you have to have the vitamins. It doesn't mean taking extra big doses of those vitamins is good for you. In some cases, too much vitamin is bad for you. Too much vitamin A can be bad for you. You have to be careful about these kinds of things and too much of anything. So I agree with Dr. Lee completely that a multivitamin as well as calcium supplementation as needed. Vitamin D for those who are vitamin D deficient, absolutely.
Okay.
One of the things we see occasionally as contributing to cognitive impairment is B12 deficiency, and that is something we do look for regularly.
Very good. Thank you very much. There was a couple of questions in regards to pain. One question came from TW that said, what is being done to remove misinformation about Black people not feeling pain? And on that same vein, there was a question from the Asian Center that said, what are the symptoms or what is the differences between pains caused by cancer versus pain from your normal, aches and pains of your bones? Dr. Cook, do you want to maybe comment on that, or anyone else? There's a you're on mute, Dr. Cook, yeah. A general misconception that
you hear me now?
Yes.
Oh, okay. Well, misconception, yes, we've heard that. A lot of that stems from, of course, the preconception of the doctor wanting to limit pain medications and not feeling necessarily, not believing the patient. A lack of communication, lack of trust on from the doctor not trusting the patient, and that's a good way to make mistakes in all sorts of aspects besides pain if you don't trust the patient's history. And perhaps another factor would be that if the doctor and patient don't have an established relationship, if they're going to an emergency room or being seen some other place by a doctor who doesn't know you, maybe they have doctors rotating, or maybe the patient is going to different places, that the doctors may not take the patient seriously. And so I think that's one of the contributing factors there, besides just general prejudice. And the other question was what?
Cancer pain,
Oh, cancer pain.
bones versus, arthritic pain, for example.
Well, one of the issues there is arthritic pain usually hurts when you do something. Cancer pain, if it's affecting your spine or other areas, you're going to have pain just lying still. So it's going to be 24 hours a day. You can't get comfortable. Usually you can have quite a bit of arthritis, but if you get in a comfortable position, you're okay as long as you're not moving.
Mm-hmm.
And it's something that if you do have pain from cancer, not all cancers are going to be necessarily painful, but it's going to be, as I say, progressive, and 24-hour a day, 7-day a week until you're given proper control, or until the cancer finally, kills you. So.
Okay. Yeah, it's
It
much
depends, of
more,
course, upon where the cancer is too. If the cancer is affecting the nervous system, the spine, or something like that, it's going to be much worse.
okay, thank you. Plus more severe. There's a question that any of you actually can answer. Are there certain drugs that older adults should not take because they impact our bodies or cognition differently than younger people? Drugs that they should not take.
I'm going to be very interested to hear Dr. Lee's answer to this question, but let me just start out by what I do. One of the things that we see a lot in older people is the combined bad effect of many medications. That is, when people are on 12 or 16 medications. I take one medication. I think if you gave me 16 medications, I wouldn't be able to be on this panel. So we deal with what's called polypharmacy, where medications in combination, some of which have value to the patient, can cause problems. Almost any medication has a greater risk of side effects as we get older. And so we use lower doses, and we start slower and go slower, and we increase them. So that's a general statement about an issue that we deal with all the time, is where we actually take away medications, because I think part of the problem we experience with our patients with cognitive impairment or sleepiness have to do with too many medications. So Dr. Lee, you can go from there.
I totally agree with you, Dr. Paulson. So if anyone is interested, there is a list actually created by a geriatrician. It's called the Beers list, BEERS list. That's a list of medications that's recommended against to prescribe to older adults. These are medications that commonly could have major risk factors, on our older adults, including causing cognitive changes like benzodiazepine, for example, even some of the over-the-counter medication, if I could name a few that we commonly recommend against. NSAIDs, so like ibuprofen, Aleve, these are medications, even though for short term are good for some pain relief, mild pain relief, but long-term wise, for people who have kidney problems or stomach ulcer, bleeding issues, those are risky and also could cause high blood pressure. So even a lot of over-the-counter medications, I would really recommend to be cautious and ask your physician first.
All right, thank you.
One thing about that is, from a doctor's point of view, it's more difficult to stop a medication than to start a medication. There's a number of things. There's inertia, that you just get used to looking at the chart. You have time constraints. It takes some thinking to review the whole list and compare things to get added on. You're going to have time to discuss with the patient why you're stopping it, because some patients are really very nervous if you're stopping a medication, and they may be more nervous about stopping when starting a new one, because they might have been told you're going to take this your whole life, And when some new doctor comes along and says, well, you know, you really shouldn't be on this, it is going to take time for you to discuss them and point out why you're doing it. And often they're very happy to get rid of some medications because of cost, worries, too many pill bottles. So that's
Yes,
what I have to say.
I agree. And as a primary care doctor for 35 plus years, I saw that a lot where they brought in medicines that other doctors had prescribed, and they always came back to me to ask me, why do I need to be on all this? There's another question here. It said, I had COVID and have had several MIS instances. I'm not quite sure what MIS is. Dr. Paulson thought it might have been multi-infarct.
I thought you said MID. If it's MIS, that would be something else. It might be might be actually myocardial infarcts. I'm not sure what they're talking about.
Yeah. If that person wants to clarify what MIS is, we'd be glad to answer that. I think I put in a typo, actually, Dr. Paulson. Is calcium good for cramps? And I'm assuming we're talking muscle cramps in this population that's probably listening today.
I think when we talk about cramps, we're talking about muscles mostly. We're talking about sudden spasms that can be caused by a muscle twitch that's very, very painful, sometimes occurs at night. Definitely low calcium state can cause cramps. So when someone does have cramps, you want to make sure they're not low in calcium for whatever the reason might be. And they would want to have calcium supplement or treatment of whatever the basis of their low calcium is. I don't see a lot of cramps myself in my own practice, and I have not used calcium pills as a treatment for it, but we do look for calcium supplement. I wonder what other doctors have to say.
I think in general, I want to make sure that the overall electrolytes, you know, you have to have a good balance of electrolytes and sufficient water to be well hydrated to prevent cramps. And the other thing I find typically a lot of cause of the cramp is lack of proper stretching. So a lot of our seniors are very, keen at trying to get healthy lifestyle. So they walk, exercise. But if they don't do proper stretching, particularly after they stop the exercise to allow their muscle to properly cool down, a lot of times they could lead to cramps at nighttime. Mm-hmm. And also I want to make sure that they also talk to their physicians about the cramps. Sometimes they may misinterpret cramps to be Restless Leg Syndrome, and the cause of that will be totally different.
Thank you. Yes, thank you. Dr. Kim, while we're talking about calcium, could you comment on if there is a relationship between calcium intake and cardiovascular disease?
Well, there are different subtypes of hypertension that people, whether they're salt sensitive, some people have implicated calcium. So certainly, as the panelists have mentioned, one, you want to make sure that when you see your primary care doctor or whoever, your cardiologist, if you're seeing a cardiologist, that your electrolytes, serum electrolytes are, within normal limits, then you have a balanced diet. But certainly there may be some subsets of patients that where calcium may have been implicated, or high sodium diets certainly are associated with hypertensive heart disease.
And I guess what I was asking, is there any relationship with calcium in the coronary arteries to
okay.
to calcium intake?
Yes, no question about it. So I think you may be alluding to the fact that sometimes patients will either get a CAT scan, and incidentally, the radiologist will report, calcification of the coronary arteries, or in fact, there are screening tests where you can get a quantified coronary calcium score that helps patients to predict whether they're at risk for subsequent cardiac events. And yes, so when someone has a presence of coronary calcium in the vasculature, that is consistent with the presence of coronary artery disease. The problem is that and with that being said, the more calcium we see in our coronary vasculature, the higher the likelihood you'll have significant coronary disease, meaning the higher the likelihood you'll have an event in the future. And so that's very important then to be aware of that, so that your doctors can counsel you and implement strategies and therapies, whether it be lifestyle or medication, to lower the risk of a cardiac event in the future. So yes, so presence of coronary calcium does indicate the presence of atherosclerosis.
Okay, thank you. Thank you. That question was clarified. The person who had COVID said that they had multi-system inflammatory syndrome. Can I get any comments about that? They had COVID and had episodes of multi-system inflammatory syndrome. No response.
I'm certainly no expert in COVID. I know that, having taken care of patients I'll tell you, in the early phase of COVID, even though I was rounding the cardiovascular intensive care unit, most of our patients actually had COVID, often manifesting as this multi-system inflammatory syndrome. That's in the acute setting. I'm not sure if they're talking about something longer term, but certainly, as I alluded to earlier, one of the major issues is that you have this hyperinflammatory response that then affects multiple organs, whether it be the brain, the heart, the kidneys, and the lungs in particular. And so it can cause multi-system organ failure, which is obviously the most terrible complication of COVID. Whether or not someone I guess I'll ask the other panelists if there's such a thing as long haul COVID multi-system inflammatory syndrome. I'm not expert in that by any stretch.
Dr. Paulson, did you want to comment on?
I would say I'm definitely not an expert. I do think that there's clearly a lot of interest in the idea that a subset of long haul COVID is in fact a continued inflammatory syndrome that could affect multiple organs. So I think that's conceivably the case. Maybe Dr. Lee or Dr. Cook has something to say.
Really?
Yeah, I have not had any patients with that situation. Yeah, I'm sorry.
Okay, thank you. It said here, recently my body was starting twitching and jerking when I laid down at night. It started mostly as the legs, but has progressed to my body jerking. Could this be a side effect from medications for bipolar disorder?
So I'll go with the sort of comment you made at the beginning, is that we cannot really provide a diagnosis and help you there. So I'm going to make some general comments, Dr. Eaton here. There are many different kinds of movements that can happen as we go to sleep at night. One of the most common things, particularly when you're very sleepy, is sort of sleep onset myoclonus. Myoclonus is a very rapid movement of the limbs. They jerk. Everyone's experienced it. Everyone has experienced when they fall asleep, occasionally an arm will jerk. And some people experience that more than others. And yes, some medications can precipitate that. But that's not the only thing that can happen in the evening. Dr. Lee already mentioned restless leg syndrome can be a feeling in the legs that forces you to move them, usually not a jerky-like motion. And then when people are asleep, they can also move their limbs, sometimes very rapidly, sometimes more slowly in periodic limb movements. So there are multiple different kinds of movements here. I would say the best thing for the person who asked the question is speak to your doctor and who prescribed medications for you and say, I'm experiencing this, and describe what those actually are. Or in some cases, we even find that when someone can videotape the movements, it helps us understand what it is, because there's so many different kinds of movements, and the speed of the movement, the frequency, what's involved can tell us a lot about what might be underlying it.
Okay, thank you. Thank you. Dr. Kim, does thyroid disease cause heart disease? Is it inevitable? You did comment about atrial fibrillation and thyroid dysfunction. Are there any other effects that thyroid disease can have on the heart?
Sure. So patients who, so either end of the spectrum with respect to thyroid function can cause multiple problems, not just in the heart, but so if you have an overactive thyroid, or what we call hyperthyroidism, or an underactive thyroid, or hypothyroidism, for the layperson, I will often tell them that the thyroid is kind of a thermostat or regulator of the body. And so when you have patients who have an overactive thyroid, as I mentioned, they can develop arrhythmias, fast heart rhythms, such as atrial fibrillation. They can feel jittery, they can lose weight. There's a number of different things related to it. If someone has hyperthyroidism that causes a rapid heart with palpitations over a prolonged period of time, if someone has unrecognized fast heart rhythm that could be manifest in atrial fibrillation, then that can cause the heart to become weak, to cause heart failure. So that's over a prolonged period of time. The good thing is that we seem to find that if we treat the fast heart rhythm and treat the hyperthyroidism, that often the heart will recover. Alternatively, or conversely, if someone has a weakened heart, we often look for whether or not they have thyroid problems that can be causing that. So hypothyroidism can also cause what we call a baggy water bottle shaped heart that we see on a chest x-ray, and that can be a cause of heart failure as well. So the best thing to do is, if you've got thyroid problems or concerns about your thyroid, is to follow up with your primary doctor who can measure the function of your thyroid through blood tests, and then decide whether or not your thyroid is functioning well or needs further evaluation.
Great, great. Thank you. What is the consensus regarding the possibility of a fourth vaccine or booster? I'm not sure what they're going to call it, but a fourth shot.
So I'm happy to answer that question. This question was asked to me a few times already recently. So in general, unless, so the fourth shot, I assume this is for 18-year or older adults. If you are immunocompromised, that means you belong to one of those groups where you are a transplant recipient who's on immunosuppressants, taking high dose of steroids, or immunosuppressants to avoid rejections of the transplants. Those are the groups that would be considered should get the fourth shot.
Okay.
So other than that, most seniors are not recommended to get the fourth shot at this point.
Mm-hmm. What about cancer patients?
So if the cancer patient's on the treatment, depends on the treatment regimen, if they are on immunosuppressed regimen.
Okay.
So they should really talk to their physician who are treating them, prescribing these medications.
Thank
I
you.
will just add that literally minutes before I got on this, I received an alert that the FDA did approve a fourth booster for all adults over the age of 50. Now, whether or not you need or may benefit from that, I think that's something you should discuss with your doctor. But I will just add that if you look at the news, literally this morning, the FDA did make that approval. I know that there's going to be a lot of commentary on that from multiple talking heads.
Well, it would be on your national news tonight, I'm sure.
Absolutely.
Another question here, Dr. Paulson, probably the supplement Prevagen made from jellyfish is advertised a lot on TV. Is it worth taking? Does it help prevent Alzheimer's?
Prevagen is probably the best example of advertisement leading to the use of something for which there is zero evidence that it's beneficial. Is that as clear as can be? I think there's no evidence that Prevagen prevents dementia or really improves cognitive impairment. I have not seen a good study of this. Do I have patients who are on it? Many. It's the most common thing that patients ask me about. And all I would say to all of you out there is, when you think about taking something, don't go into it thinking, I know this is going to cure me or make me better. If you're going to try something, approach it like a scientist. Try it and see if it makes a difference. If you clearly feel better on it and you're tolerating it well and it's not pinching your pocketbook, I'm okay with that. But if you feel worse, stop it. And if you don't notice any improvement at all, stop it. There's no reason to add more things in your body that are probably not useful. So that's a pretty unvarnished statement that I don't believe that Prevagen is useful. And I'd love to hear if others on the panel have something else to say about it.
Well, one thing to say is, whatever you're taking, make sure you let your doctor know, or if you're going to have surgery, definitely let them know. Some of these can affect bleeding and other such things, hypotension.
What I tell my patients is, when they ask me whether or not they should be taking supplements, is that to Dr. Paulson's point, for many of these supplements, there are no good studies to show real benefit that are advertised on the news, on the media. What I do tell them is, if these supplements are very, very expensive, then you have to think about that, but make sure to take your prescribed medications that we know have benefit, because I've seen patients take these supplements in lieu of the real medications that we know have benefit. So I always emphasize the importance of taking the medications that we know are beneficial, that have been prescribed by their doctors, and not to substitute them.
I think the same answers could be applied to one of the questions that in the panel, Shelling asked about the Chinese seniors taking the herbal medications. Same things. We really don't know the effect in what's in these medications, even though they're thought as supplements. But we do know some of these medications could potentially cause bleeding issues, low platelets, and liver damage. We have seen them and has been documented. So be very careful with taking these medications.
There's a question related to the COVID vaccine. Do we know how long it might take for research to show if the vaccine itself has an impact on our bodies or our brains? And I know that's probably a question that's difficult to answer, but
I'll take a stab, because as a neurologist who has no vested interest in virology or treatment of infectious disease, I'm a little bit of an outsider, but I also read the literature extensively. And I think what is very clear is that the benefit of all the vaccines that are used in this country are quite remarkable. The reduction in deaths and severe illness from those who've been vaccinated and boosterized is really remarkable in the last 6 months. There's just no question about that. People who have not been vaccinated are still dying at a high rate. And so the effect of the vaccine short term is that it's absolutely helpful in preventing disease. Now, do vaccines on occasion cause problems? Yes. All vaccines that we can give to people can lead to, in a very rare instance, an inflammatory or an autoimmune response that can be problematic. It's happened over the decades in America that occasionally a vaccine will cause a higher rate of that, but it's a rare thing. In terms of chronic effects of the vaccine, it's hard to say that there isn't anything there, but I would be surprised if there are chronic effects of the vaccine itself, whereas we absolutely know that there are chronic effects of a significant infection from COVID. So if I can say here, the pitch, that if you have been on the fence about whether to get a vaccine, I'm telling you that my experience as a neurologist who's seeing it from a distance is that the benefits so far outweigh the risks of the vaccine that I would strongly encourage you to get it.
Thank you. Thank you. Are there any simple self-assessment tests to help check mental health status? And I'll just comment that when I was in practice, we did have screening tests that we used in our office all the time. And I'm sure you all on this panel have similar office screening tests for mental health conditions. Can you comment?
I think it would be best to hear a non-neurologist, non-cognitive specialist answer that question. Are you using these kinds of screens helping people for self-assessment? I'm curious.
So we always do it in the clinics. I don't know, Dr. Cook, I guess we use PHQ and PHQ, there's PHQ-2, PHQ-9. So just 9 questions or 2 simple questions to screen for depression. And the patients fill them out, but obviously the physician review the results and then guide them based on the results. And also the geriatric depression screening question also too, there's 15 questions or 10 questions.
Well, certainly asking the question raises some, if you're asking that question, some definite possibility that you have some depression. And the PHQ-2 just basically asks you feel depressed, down, or tired, or these sorts of things. But if you think you have depression, you probably ought to talk to a specialist about it. It's something that people put off for a long time. And you can go, some people put it off for years, never make that move to talk to a counselor or other doctor. Something's harder for some people to bring up than others. But I wouldn't try to self-analyze too much. Just analyze enough to say, I think I have a problem, then try to go take some action on it.
All right. Thank
And
you.
also, if I could add, is that Medicare recommends an annual wellness visit. So
Exactly.
every year, seniors should go to their family physicians to have wellness visit. And as part of the wellness visit, a depression screening should be done. So
Okay.
that should be done, yeah, and a cognitive assessment as well.
It's common to see Chinese seniors taking medication prescribed and supplied by their doctors in their original hometown back in China. Is it a good thing to do? Are there any risks when they also receive medical services here in the States? I think we've kind of answered that a little earlier in terms of letting your primary care doctors, all your doctors for that matter, know what you're taking. Now, I could see where we in the state may not be as familiar with Chinese medicine, however. Any comments on that?
I think my take is that a lot of the medications, they are fairly diluted concentration because they come from the original roots of the medications. But if you take it for long term, they could also potentially have side effects. Some of the common side effects we have seen are liver damage or platelets or hemoglobins, so blood system damage. So
Okay.
I think it's just to make sure you let the physician know that you're doing that, otherwise the physician will see something or not knowing and prescribe you medications and not realizing what's the cause.
Okay. All right. Thank you. Thank you.
I do see the elderly Chinese, the parents coming in and taking their medicines we prescribe sporadically, depending on how they feel, they'll take it or not take it. In those cases, it's great to have the son or daughter come along, and they'll be able to give you a little more history and maybe convince the parents of the need to take say a daily hypertensive medicine as opposed to just seeing how things feel.
Okay. What about taking a baby aspirin a day for seniors? Dr. Kim, what's your thoughts on baby aspirin a day?
Yeah, it's a great question and very complicated question. So let me start off by saying that we definitely know that there are certain patients who ought to be taking aspirin. So the ones that's fairly straightforward. If you've had a history of cardiovascular disease, if you've had a heart attack, if you've had a stent, if you've had a stroke in general, you need to be on a baby aspirin, and you'd be on that indefinitely. And then we know the patients, this is fairly new, patients who may have been on an baby aspirin before, and in this case, it's baby aspirin, not an adult aspirin. We don't, we're finding that that baby aspirin, 81 milligrams, is as good as an adult aspirin, and we're finding that you just get increased risk of bleeding, and the Europeans taught us that because they were ahead of us on that one. Patients who are on anticoagulants such as Coumadin or Eliquis, patients who have atrial fibrillation, we used to have them on both aspirin and a blood thinner like Eliquis, or I don't want to. I should use the trade. I shouldn't be using the commercial name, but oral anticoagulants. That if you have chronic stable coronary disease, so even if you've had a heart attack before, if you had a stent, you can stop the aspirin after a year. So I think that that's a discussion you should have with your doctor or your cardiologist. If you're on one of these oral anticoagulants, should you remain on an aspirin? I think very clearly there is increasing data that the risk of bleeding is significantly higher in the older population. And in general, you don't need to take both. So that's that. So then the complicated question is, for those who don't have a history of coronary disease or heart attack, is there benefit to aspirin as a primary prevention, meaning to prevent your first event? And again, this is kind of a moving target. Everyone's heard that, an aspirin a day keeps the doctor away, but actually, again, there's much more emphasis looking at preventing complications related to these medications. And so for older patients who have not had a cardiac event, 60, 65, I'm now telling patients to not take aspirin, to stop their aspirin, because the risk of bleeding basically offsets or is greater than the benefit of continuing to take a baby aspirin. For those in the middle age group, say 40 to 50s, in general, I'm recommending that they don't. But again, it's one of those situations. There may be benefit for those patients in their middle ages who are at higher risk, say greater than 10%. So patients who've got strong family histories, hypertensive, diabetic, high cholesterols, then you may benefit from a baby aspirin. But then again, you have to understand that's offset by the increased risk of bleeding. And so then you have to kind of you have to take into consideration what's the risk of bleeding in that particular patient. So again, those are conversations you should have with your primary care doctor.
Okay. I think we are going to pause at this point, and we're going to have a couple poll questions. They will appear on the screen, and we simply ask you to select your response. And for those who are non-English speaking, the poll will be in the chat, and the interpreters will read the question and get your response. So, Karina, whenever you're ready. Oh, we can't vote.
I want to vote, but I can't vote.
Is there another one?
Well, it certainly can be hugely expensive, not only in things you have to buy, but the time away from work, transportation. There's many things you're going to wind up spending if your parent is needing care.
I think we have one more poll question before we move on. Is that correct? We do not, is what I was told. Okay. Well, we will move on. One question came through. They were asking a question for their neighbor to want to know if AARP would cover the cost of long-term care if we had to go into a nursing home. And I would venture to say no, unless you have long-term care insurance through AARP. However, maybe our state director, Paula Cunningham, can answer that question as we go forward. Are there any negative effects for older adults taking antidepressants?
Well, there's negative impacts if you are depressed of not taking antidepressants. However, also, if you can afford it, counseling can be very helpful, help you more with problem solving, the stresses that you're facing that may be making you depressed. So, but they're certainly going to have to look at some negative impacts. Is it going to cause drop in blood pressure when you stand up, or hypertension? So that's a thing. Excess sedation, depending upon what the antidepressant is. So it may require taking different things in lower doses than a younger patient. But depression is can be quite a severe problem in the elderly, shortening life, shortening enjoyment of life and activity. So there could be side effects or concerns, but you have to weigh that against lack of treatment.
Mm-hmm. Okay. Dr. Lee, any
Well,
comments?
yeah, thank you. So I think every medication has risk, right? Has potential for side effects. So we always have to consider the benefit of taking the medication versus the risk of taking that medication. So, like Dr. Cook said, if the benefit outweighs the risk, then we should continue the medication. But the physician and the patient should always ask is, do I still need to be on the medication? If I've been on this for so long, my depression is well controlled, then should we try to taper it down, to see if I could still remain depression free and without so much medication? Always cutting down the dose, or tapering down the medication with the guidance by a physician. I think that's the best way to consider.
Okay.
Another thing in depression, you want to make sure vision and hearing are evaluated. There may be some factors there that are making the patient depressed.
Mm-hmm.
Social factors as
Right.
well.
Right.
Mm-hmm.
Okay, we have a comment question, I guess, from Peggy. It says, for a person to have a good immune system, their immune system needs to function and fight off bacteria and other harmful things. For the past 2 years, our seniors have been mostly at home due to the pandemic, and we have a question about how to keep the seniors protected while not being overly protected. In other words, how do we keep seniors' immune system working while not overwhelming their immune system?
Boy, Peggy, that is a really insightful set of questions and comments. I will just say this in terms of optimal brain function, which ties also with optimal heart and muscle and skeletal function. There are a couple of things that are very important, and they include physical activity, aerobic exercise, and social and mental activity. And I think that one of the things we didn't even talk about in our opening comments is how COVID has left people sequestered in their home in an environment where they're not stimulated in those ways, physically, socially, mentally. Those are critical to the immune system too. They're very critical to the immune system. So I think the question is a very good one. And I again, part of this is vaccination. Part of it is being careful with whom you interact. If you're comfortable wearing a mask in situations, regardless of whether someone has symptoms. And as the weather gets nicer, and hopefully it will get nicer real soon in Michigan, to be outdoors, because I think you can safely be outdoors and get your immune system going, get your heart going, get your muscles going, and get your brain working better. All of that's very important.
Thank you for that. I agree. This sequestering the last couple of years has really had an impact, not only on seniors, but I think on
Everyone.
Everyone. I'm concerned that my parent is no longer safe driving a car, but they think they are fine. How often do you hear that? Can I contact their doctor about this is the question.
Yes,
please.
you can contact the doctor.
And I would say the best way to deal with this, in my view, is to have that family member come in with the patient to see the doctor to discuss this. So the doctor can be, if you will, the bad cop here, not the family member. And there are things we can do to validate that someone has driving issues. For us, there are a lot of reasons why older people are less safe driving. Everything from poor vision to poor mobility to frankly cognitive impairment. All those things can contribute. And there are ways we can actually assess drivability at the state level or through, for example, in Michigan, we have a program on drivability where people can be evaluated. And what we try to do with dementia is to scale back the driving. I just said how important it is to be engaged in the world around you. And then if I tell someone who has mild cognitive issues, oh, we're not letting you drive anymore at all, that can be a real downward in brain function. So we will scale back the ability to drive in very local areas, and we'll make sure we eliminate distractible factors. But I personally like to see the person come to the office so we can have that discussion.
I totally agree with Dr. Paulson. So we always ask about whenever there's family concern about a patient's cognition, we always ask about the driving safety. So we could do a clinic screening test. It's called a Trails B test that has some validation to predictive of us driving safety in a clinic. And we also have occupational therapists that we can refer to get a driving safety evaluation. So they not only test their ability to recognize the road signs, but also if they pass those written tests, they can take them on the road to watch them how drive, to provide recommendations, and also whether if they're safe to drive or not.
Okay, great. Thank you. I think there was one more here. It says, for my wellness visits, I complete the info. I have never seen the doctor even look at it. I know for the wellness visit, the medical assistant asks a lot of questions, and yes, your hand's up, Dr. Paulson, go ahead.
Oh,
you're on mute. You're on mute. Dr. Paulson, you're on mute. Can you unmute?
Oh, sorry. I wanted to say I must go. I really enjoyed this. And I do read the wellness sheets when they come through, but I do think there's a lot of times we miss out on the information people provide us. So I've really enjoyed this. So.
Well, thank you so much for joining us today. We really appreciate your input.
Thank you. Bye-bye.
All right. And as we start to actually wind down, we wanted to talk a little bit about what we as seniors and as even non-seniors can do to just to stay healthy in general. Dr. Paulson alluded to a few things a minute ago about the importance of physical exercise, of interaction with others. Can you comment, even from a cardiovascular standpoint, Dr. Lee, Dr. Cook, and Dr. Lee, can you talk about what we need to do to just be our best selves as we move forward?
So in general, I say we start from where you could do. Walking, these are cardiovascular exercise. They help with the heart, muscles stay healthy. That's the common thing that most people could do. If you have arthritis, then I recommend considering something more like in a water type of exercise. If there's a local gym, they a lot of times have arthritis foundation providing exercise in the water to help you get started. But then don't limit yourself to one type of exercise. So cardiovascular is one type of exercise people commonly do, like walking, biking, etc., or running. But then also need to want to add something like resistance exercise, like weightlifting, to help build up your muscle, because we need the muscle to help our metabolic system to prevent diabetes and remain strong. And then the other type of exercise I also recommend senior to do is balance exercise. So this type of exercise is, for example, like Tai Chi, that could help you keep your balance, prevent falls, particularly people who have risk of falls. Primarily these three, I think. I don't know if Dr. Kim or Dr. Cook have any other type of exercise you would recommend, but that's where I would recommend my patients to start with. And obviously start slow and then slowly increase by setting a realistic goal, sort of like I want to add an extra 1,000 steps the next week, or add 10 more minutes of exercise in the following week if I could do it. But set a goal that's realistic and achievable.
One of the most important things is to, it's sometimes hard to get started. You have to really say you want to do it, get a reason for why you want to do it. If you want to have you have more energy to go see the grandchildren or the walk or something like this, but you have to make it a habit that you're going to do this exercise. It's easy to think when the time comes to do it, well, I'll do it tomorrow. So that's a big thing. You want to just find some exercise that you enjoy, you're going to stick with. If you like to do it with some friends, or sometimes that'll help get you off the couch when you might have said, oh, I'll let it go another day. If you have somebody coming around, maybe put it on your calendar, make it like an appointment that you're gonna do this at this time, as opposed to putting it off and then discovering it's dinner time and then time for bed. So those are things I recommend.
Great. Dr. Kim, from a cardiovascular standpoint.
Yeah, I would, absolutely echo the comments already made by the panelists. Set realistic goals, because, often patients come and say, I'm going to start an exercise program, and they get on a treadmill. And I mean, I know I do this. You get there within five, you start 5 minutes into it, you're like, oh my God, I can't go anymore. Well, do what you can do, and don't get frustrated, and stick with it and be committed, because it will get better. So I think that's one thing. And then from a cardiovascular perspective, we like to encourage our patients when they, to know their numbers. That's kind of the mantra. So when you follow up with when you see your primary care physician, or, increasingly you can even do this at home, know what your blood pressure is. I tell all my patients when I see them is keep a blood pressure log. You don't have to be obsessive over it, but once a day, once every few days, if you have a blood pressure monitor at home, which is I find very helpful as I manage patients with hypertension, is to keep a diary and then share that with your doctor so they know what. It's not about just checking your blood pressure and knowing what it is at that one point in time in your doctor's office, but what it runs over a period of time. And that's particularly important for older patients who tend to have more labile or pressures that are have a much larger range. Make sure you know what your body mass index is, or your weight is relative to your height, so that we know what your cardiovascular health is related to relative to your body habitus or your size. Know what your cholesterol is. So those are things that are important that you can do with respect to seeing your doctor, and knowing your numbers will help you maintain your health.
Great, thank you. I might also add the importance of sleep hygiene. Many seniors tend to have issues with inability to sleep well, or to sleep as long as they need to. And I think for our mental health, I think it's also important to keep learning, to keep reading, to keep exploring, to have expectations. Those are the things that keep us young and keep us going, in addition to certainly our physical well-being. So I'd like to add that. And I just want to thank each of our panelists today for joining us, taking the time out of your busy schedules to be here and answer the questions. I'd like to thank the attendees who have put questions into the chat, and I hope that your questions were answered appropriately. And if we did not get to your questions, you can still put them in the chat, and the staff actually will reach out to you and try to get your questions answered. So at this time, I would like to turn this over to our AARP State Director, Paula Cunningham, for closing remarks.
Wow, I could just drop the mic and go home. It's just been so phenomenal. And for you doctors, all of you, to give so much of your time, your wisdom, and your expertise to help other people and to reach out to other people. We cannot thank you enough for that. And for all of the interpreters who have been diligently making certain that everyone got their questions answered and in the chat, thank you also. This is historic for us today, to be able to provide this type of information in 5 different languages at the same time, in real time, is a game changer. And to this wonderful committee who has worked for quite some time now with all of us to make certain that this was an event that was effective and inclusive of everyone, we say thank you as well. It's important for you to know that this is not just a one and done, but this is the beginning of many conversations that we will have. The next Color of Healthcare event that we will have will be on June 23rd. I did put information on it in the chat. It will be in person along the Detroit River. We'll come to Detroit for that one. We'll also have some buses for people who are coming in from Grand Rapids or Lansing who may want to attend if they'd like to drive and ride the bus instead of driving. And that will be an opportunity for you to actually get a community resource kit that we've been working on with this phenomenal committee of the resources that are available in your own community where you can go to get answers and questions. We've been very, very deliberate and very involved in making sure we gather as much information as possible. So it will have a resource kit that we'll be handing to you, physically handing to you for you to take with you, as well as a wonderful lunch along the beautiful Detroit River. Some of you may not have gotten your questions answered. As Dr. Eaton said, please put those in the chat. Also, I'd like for you to put in the chat one last request, please. What you would like to know at the next Color of Healthcare forum. What questions, what comments, what topics would you, not questions, but topics would you like to have covered? As the committee reconvenes, we'll take a look at what you put in the chat in terms of topics you'd like to have covered and make certain that we include those in the next forum on June 23rd. That forum will be in person. Again, it will last a little longer. It'll probably go, I think it's from 11 to 3, but again, information will be given to you for that. To all of you who joined us, thank you so much. Please tell your friends, your neighbors, share this information. That's something that you can do. Share the information with others to make certain they also have access to the information that you've received today. So that the entire committee and to the team that pulled this together and to all of you who are watching, stay healthy and then stay informed and stay vigilant about your own health. You are your own best ambassador for taking care of yourself. So thank you so much. I appreciate all of you. And to the committee, everybody, let's wave goodbye to everybody. You've done a phenomenal, phenomenal job. Doctors, thank you so much. And Dr. Eaton, you know I love you dearly. I appreciate you. Thank you. Bye-bye, everybody.
Bye.